So good afternoon, everyone, and thank you for joining us for our 8th workshop for this rulemaking. My name is Amelia Boyd, and I am the program manager for the WMC. I will be facilitating today's session. This workshop is being recorded, and we'll post the recording to our YouTube channel soon. The documents we'll be discussing are available on our website at wmc.wa.gov. In this slide deck, the globe and YouTube icons are clickable and will take you directly to those resources. For attendees, if you would like to ask a question or make a comment, please use the raise hand function. We'll call on you as soon as we can. When offering comments, please avoid reading aloud any written remarks that are already included in the materials. These workshops are intended to be collaborative with a back and forth exchange of ideas about the proposed language. Before we get started, I'll take a roll call of our panelists and staff. When I call your name, please introduce yourself. Marlon?
Good afternoon, Marlon Basco. I'm a policy analyst with the Department of Health, and I support the commission with policy work and rules work.
Thank you. Dr. Chang?
Hi, Poshan Chang. I'm one of the commissioners. I'm a retired family physician.
Bonnie?
Afternoon, all. Bonnie Gregory. I'm with the Washington Medical Commission, assistant to Amelia Boyd.
Thank you. Heather?
Good afternoon, Heather Carter, Assistant Attorney General and Legal Advisor for the Commission.
And Kyle?
Good afternoon, everybody. I'm Kyle Kiernan. I'm the Executive Director for the Commission.
Dr. Lee?
Hello, everyone. I'm Dr. Jennifer Lee. I'm one of the commission members for Washington.
Thank you. Mr. Lopez?
Hi, good afternoon. Ed Lopez. I'm a PA in Internal Medicine and Vice Chair of the Commission.
Thank you. And Micah?
Good afternoon. Micah Matthews, Deputy Executive Director for the Commission.
And thank you. Dr. Domino, please introduce yourself and then begin the script.
Sorry, it's being slow. Hi, I'm Karen Domino. I'm one of the commissioners, and I will be the presiding officer for this rules workshop. Today is Monday, June 1st, and it is now 1:09 p.m. The meeting is being held via Teams webinar. The rule being discussed today is regarding opioid prescribing general provisions in Chapter 246-918 WAC for physician assistants and Chapter 246-919 WAC for physicians. The CR 101 or pre-proposal statement of inquiry was filed as WSR number 25-10-039 on April 30th, 2025. Ms. Boyd, please present our proposed timeline for rule development.
So here is our proposed timeline for this rulemaking, which may be adjusted as workshops are held. If there are any questions about this timeline, please use the raise hand function and I will call on you. Okay, doesn't look like there's any questions.
Okay. Well, thank you. Just a reminder that we do have future workshops scheduled for this rules making, which Ms. Boyd will present later in the workshop, and I think she already showed the timeline up there as well. The first item on the agenda for today's rulemaking hearing is the discussion of MMD limits and the consultation threshold requirement. Ms. Boyd, please present the draft language for that section.
All right, so here, and I just lost it. Hold on just a second. So here's where we're starting today. All right, so we are making the first change that we're making in this section is changing the shall to should. And then we've added some new language later on in this section. And these are, and then just note that the changes here may affect some other sections that we are working on, as well as the definition section. But this is where we're starting today.
Ms. Boyd, can you read those? It's very hard to see on the computer
Oh,
with the
hold on,
black
let me,
and the red.
sorry, let me
Yeah,
change
yeah.
my view.
Oh, okay.
There. Hopefully that's
Okay.
better. I'll make it a little bigger.
Yeah, thank you.
Okay, let's see. So we've had discussions in the past about making some changes to this section. We've also talked about not having a threshold requirement. So right now, I think it's at 120 when we require that they do a consultation.
Hasn't then there been feedback that there, I saw some written feedback from an email that recommended not getting rid of that requirement?
Right. We have had feedback for both ways. So we've had feedback that says we should keep the 120, and then we've had feedback that says we should eliminate all MED requirements. So that's why we're discussing it today.
I think the pain specialist was one who recommended keeping the requirement.
Go ahead, Micah.
Like, this is a question for either you, Amelia, or Heather. What's the statutory status of MMEs? Is that still part of the statute that we have to keep it as something, or is it just a recommended, or it just tells us that we have to have an MME but doesn't specify the amount?
So this is Heather. So 1871 450, which is the legislature did not repeal when they adopted the subsequent, let me look, the other rule, which is 800, but 450 was not repealed. It does say that the pain management rules contain the following elements. One of them is dosing criteria, including a dosage amount that must not be exceeded unless a physician first consults with a practitioner specializing in pain management. And it goes on to say there can be, special circumstances that it can be exceeded, but there is that requirement that's still in. It's in in 2A. 2A I little I big A. Unfortunately, the legislature did not repeal 450.
So that means we need to keep one in there. Is that correct?
Yeah,
a recommended one.
Something in there. The legislature is saying that you need to adopt a rule that has this. Right now, you have it at 120. That doesn't mean you can change the amount or reword it to somehow not have an actual number and consider other things in a dosage amount. But there needs to be something in the rules about, exceeding a certain amount and needing to have a consult.
Yeah, well, I think wasn't the pain patients didn't want to have that amount, but it sounds like we need to, correct?
You need to have some dosage amount,
Yeah.
but the legislature didn't define what that is or how you would define it. You have that discretion.
Dr. Lee, do you have any suggestions on that?
Yeah, I think this is a really tense issue, and it might be one of the most kind of hot button issues in this recommendation, because patients on one side feel that they are restricted by what they will describe as kind of an arbitrary number that isn't individualized, which is a reasonable a concern. And it has also become sort of in some practices used a little bit dogmatically by providers who then say more sweeping statements like I'm not allowed to, or it's illegal to prescribe above this number, therefore I won't, which isn't not what it says. And then on the alternative, we've had feedback from the community, specifically from some pain management providers, as well as primary care, who feel like it is a little bit of a support to them in order to sort of help in the conversations they have with their patients about the limits that are beyond which risk is thought to escalate. And the 120 milligram MED is, I would say, a bit on the liberal side. I mean, when the CDC has commented on this, they've since reached, the CDC currently has moved away from having any milligram definition, but previously its milligram definition was lower than 120. And then I can say that our like as a provider in the VA healthcare system, the MMED limit in VA after which which is identified as the threshold for thereafter an elevated level of concern and consultation is actually 50. So I would say, I think in my opinion is if we must have a number, that it's my opinion that perhaps leaving this number as it is, because I think that there are reasons to increase it and reasons to decrease it. There isn't any data point or a piece of research that specifically points at a MMED as being, the threshold that after which we can reliably expect increases in accidental overdose. It happens that it's much more of an individualistic kind of risk that is influenced by medical comorbidities, other medications, age, renal clearance, and many other factors. I think changing this number either in either direction is going to be equally unpopular. So knowing that, my thought is just to leave it alone.
Thanks. See number 1, hand raise. Sorry,
Go
you're
ahead,
very
Rose.
small.
Hi guys, it's Rose here from WashPip. I love the change from shall to should. I think that's first of all clearer because the shall consider was super vague, and so should is a better use there. Second, I dug into this a little on the weekend to see if other states had this mandatory consult threshold at a particular dosage, and the answer is no. We are the only state that has a mandatory consult threshold for a pain specialist. And part of that reason is because this was back in 2009, and this was like the first opioid legislation in the country. And the 120 number came from, there was no evidence for it. The quote from the paper, it's from our own Gary Franklin. The guideline was implemented in April 2007 as an educational pilot and focused primarily on dosing guidance for patients at or above 120 milligrams per day. High-quality epidemiological studies on dose-related mortality risk were not yet available, so this dosage was based on the experience of the advisory group in the room. So they literally just picked a number and used it. If we have to have a number here, though, which I think honestly, I think in the future, this should go. If we have these rules and the guidance clear and safe with enough guidance, then we shouldn't need this, because the requirement to send people to pain specialists, one, as a choke point, a bottleneck, if you will, to treatment, because there's only so many pain specialists in the state. And there are fewer of them than we would like, and we've lost a few since these rules were passed. And second, it costs us more to go have a copay for a specialist visit than it does for our primary care. So in a world where a primary care physician could treat a stable patient, that'd be better for patients. But if we're stuck with it, I agree with Dr. Lee, let's leave it alone. Let's just not touch it, because we'd be making up more numbers out of thin air if we made it higher, and we'd be relying on making it lower. I think is a bad message to send when we're trying to get away from dose-based risk. The risk is in the patient and their behavior, less on the actual dosage they are on. So I don't love it. I wish we could toss this whole thing, but if we have to keep it, let's change it to should not shall, and leave it alone, I think.
Thank you.
I agree with you. I agree with you, Rose. And, you know, in 2009, when this was first instituted, this number was a bit arbitrary, but it was also a very different situation where the majority of opioid overdoses were occurring with the combination of methadone and benzodiazepines in like as outpatient prescriptions for anxiety and pain management. And today is a completely different day. We have, you know, a much lesser contribution of methadone in opioid pain management for chronic pain. And most of our overdose deaths are now occurring as the consequence of fentanyl and other illicits. But I do think that, you know, since we don't have guiding data, that it would be really arbitrary. It would be hard to justify why we decide to change this number. I look forward to the day that there is not a number and we can really focus on optimal and individualized pain medicine treatments. But until we don't have that legal responsibility is elevated, I would say let's leave it.
Yeah, totally agree.
And the stuff in red that's there, does that, we should still have that or not? I can't,
So these are some
see.
suggested additions.
Uh-huh.
So if we start with 1A, 1A is already there, who are
Yeah.
under 18 years of age. And then these are some suggested revisions based on feedback and comments and things like that. So
Oh, okay, those are just special attention. It doesn't deal with
right.
this
Right. The 120 we
arbitrary
haven't.
120 MME.
Yeah.
Yep. And this is actually where the emphasis should be, is on having a complex assessment of risk, which is what is described in red. So it's good to keep this here because maybe there'll be a day where we can delete the 120 and just leave this part in place.
Yeah, I guess someone has to change the law.
Mm-hmm, mm-hmm.
Get the legislature to make a change.
Go ahead, Cindy.
I see.
Hi, thanks for coming today. So when looking at the extra reasons that we have listed here, it's another another reason that a prescriber will pass you on to a pain specialist. That's what we're finding now, is that at 120, everyone's getting referred out. At 90, everyone's getting referred out. Everybody is getting referred out. So if you have the 120 and this list of things that basically describe people with complex pain conditions, then it's going to be another reason to pass a buck.
Well,
I mean, my only feeling is that these things need to be identified, and it's basically an educational thing for primary cares of who might have more be a more challenging patient. So I thought it seemed reasonable.
Yeah, and the requirement is that over 120, that somebody receive a consultation, not ongoing management by a pain management doctor. I mean, the reality is that if a primary care or anybody else who has been the initial prescriber of an opioid pain medicine is looking for a reason to, quote unquote, pass the buck, they'll find a reason. I don't think that this, in my opinion, I don't think this is going to like strengthen that cause. I think this is like describing responsible decision making around this medicine class.
Hey, this is Rose. I'm sorry, I got interrupted for a second. Why do we need to add all of this stuff to this section where we didn't need it before?
Yeah, so at the last meeting, Rose, we talked about, like, as a moment ago, you and I were agreeing about how, we should be really making decisions on the selection of an opioid medicine at all, and also if they're, dose selections based on, a comprehensive and individual assessment of a patient and what's right for them. And so this is a description of some of the most key characteristics that a provider should consider if they're considering an opioid medicine. And they're also characteristics that a provider should consider surrounding if the patient should have a pain medicine consultation. But this isn't a requirement. This is just a request for special attention to be given to patients with these conditions.
But don't we already have it in here that when a patient becomes a chronic patient as after they've graduated from acute to subacute to chronic, that they get reevaluated as if it was a brand new, evaluation, brand new consult, that they would cover all of these things? That's already in the chronic section.
We can look at that. I think that, the designation of 3 months as being the time point between movement from subacute to chronic pain is probably as arbitrary as 120 MMED. I mean, 3 months doesn't really, there's nothing specific about that point in time. It's just been an understood like mark in the sand for when we're going to start considering patients chronic, because for the most part, any acute pain condition would be likely to have kind of healed maximally or resolved maximally by that point. And then when a patient is designated, regardless of whether they're acute or chronic, these sorts of things should be considered. But especially if you're, really looking at a decision to have chronic pain medication be an enduring treatment plan. I mean, if it's a patient that has acute pain, if they're post-surgical, regardless of whether they're 18 or regardless of whether they have any of these risk factors, if opioids are necessary to treat acute pain, it's going to receive a different consideration than if somebody is a stable person who has chronic pain. I think we need to look at those two scenarios very differently.
Yeah, I guess I'm just wondering if that is true, then why wouldn't that apply to all chronic pain patients, whether they are referred to a specialist or whether they're being treated by primary care? Because that seems like it should be in section 910, which is treatment plan for chronic pain. If you're going to consider prescribing for a chronic pain patient and you think that those things should be considered, then they would go all up in the chronic pain section, not just in the referral piece. Yeah.
I see what you're saying. Yeah. Can we look at that the chronic pain treatment section? 910. Thank you very much, Amelia. So you can, I think I see from this language here, Rose, that there's really, it's much less explicative, right?
Right.
So I appreciate what you're saying, that, perhaps any patient with, even if a primary care provider is anticipating being the enduring prescriber for opioids, those same things should be considered. And I can agree with that.
The other thing is, I I don't know if Jed's in the room here, but we were trying to get away from being overly prescriptive. Like the guidance is so long that the reality is, I don't think your average physician, be they primary care or be they a pain specialist, is looking at the how many thousands of words do we have in here? And if they are treating a person has complex or chronic pain, if they don't know the things to look for, or that people under 18, or that people with comorbidities, or like all the other things are areas that they need to check, then we have a bigger problem with licensing doctors in our state, is my opinion. I hate to get more prescriptive at a time when we're trying to make this cleaner and simpler and give providers more autonomy to do the right thing.
Yeah, I mean, I think the simplicity in language is important, but it's also not a simple treatment. I mean, the reason that we're spending this much time is because there have been many, many, many deaths, like atrocious.
There's been many deaths from illicit drug use. There's been so few with prescriptions, so few that ADI can't even, I mean, if you look at the ADI list, there's more people dying with alcohol in their systems than there are with prescribed opioids.
So we're talking right now about the prescription opioids. And
right.
And so I think that's where I want to make, I don't want to go
I just
too
thought, let me
tangent
just
here.
say, I thought that was fine to add those things. To me, they seem predominantly educational. And there may be other spots to be able to cut language if we're concerned over the amount of language.
So we're saying that for people that get referred to a pain specialist, we think the pain specialist won't know to check those things?
The pain specialist will, but who's going to, maybe the referring physician won't.
No, but the referring physician won't be checking them because they'll say, I'm referring this patient because they're above 120 or for whatever reason to a pain specialist. And that's when this section applies,
it just said special consideration. Consider doesn't say anything about referrals.
So it could mean that there's a patient that's being treated by a primary care provider on chronic pain medications who had been fine, and then there's an escalation in opioid therapy or increasing complexity of medical or behavioral conditions, and then that is a reason they need to have special consideration or special attention for whether a referral is indicated.
So in that scenario, we're thinking that there's primary care physicians treating chronic pain patients that don't know that if things get complex or complicated, that they should refer to pain specialists?
We're hoping that they would, but this is a guideline that it describes optimal procedure. And so then if that provides a framework for people to reference who may not be certain of the expectations.
I just think this is not necessary and adding more complexity and a lot more words when we're trying to make it simpler. Escalating opioid dosage without sustained improvement in function. You don't think people are going to know that, like, you're not getting better, you're getting worse?
Definitely not. I mean, as a pain management physician of the past 15 years, on a daily basis, I see patients that come to me with high dose or moderate dose or low dose opioid pain medicines, and they are referred to me because they are requesting higher doses, but the lower doses haven't been working either, and they're not functioning well.
Appropriately referred to you when that happens. That's what you're saying already.
Yeah, and I'm certain that there are many that are not referred for consultation in that circumstance as well. And this is a guide or a suggestion to open patients up to having the opportunity for expertise when established opioid pain medicines are no longer functioning effectively.
Yeah, so what I see here is like what I just said, the thing about there's a bottleneck where patients that need to see a pain specialist can't because there's not enough of them, and the wait list is long. And this is telling anyone who's not a pain specialist, here's a whole other list of reasons why you should not be prescribing pain medication, if you even are.
It just says should consider. It doesn't say you have to refer them. I just, MH, maybe if you could, you've had your hand raised for a while.
It's Maria. Go ahead, Maria.
Hey, everybody. I want to say I 100% agree with Rose. There is such a difficulty out there for patients getting in to see pain management that this is just going to create more issues when we're trying to solve those issues. One of the things that are in there is like the deterioration in function and pain. This comes up quite a bit, and there are so many people that who have worsening pain and function, and a lot of reasons for that, the underlying disease progress. So, you know, if we just put that in there, we're not considering that. All these words are just going to make it so much more difficult.
We're adding 17 new things to consider, where before we said if you should consider referring the patient as needed to achieve treatment objectives, or if they're above 120. And now here's 17 more things for your average doctor to read and retain, maybe. Where before, most primary care doctors are not prescribing long-term opioids. And if they are, if they read this, they're going to be like, yeah, nope, I'm out. At a time when we're desperately trying to get more providers to treat pain patients, be it chronic or not. So yeah, I just feel like this is a sledgehammer to this section that's not going in the right direction.
So I just wanted to hear from the other two commissioners on here who
Yeah,
do, you know, yeah,
I
thank
was going
you.
to chime in. So as a retired practicing family physician, primary care, this actually it's a kind of very expensive. It serves as a guardrail for the primary care physician because without this guardrail, it can be all over the board. You can have good doctors who will try to do everything possible, but then you also have the ones that who's not quite sure, and because they don't, even though we say we know the patient, but any little change, like patient had a surgery and they basically escalating dose, but they don't decrease it. And so this service is that, well, how come I keep increasing the patient pain is not getting better? So this kind of help the primary care physician as the guardrail to serve that. And I understand that, referring to the pain specialist, that's a bottleneck. But there's this does not, say that it has to be an in-person consultation or treatment. And I know so because the UW actually, they have a special pain, kind of, calling any time on Wednesday, as a kind of specialty served for the primary care physician, that if you have any complicated patient, you call them on that special day. It serve as a consultation because you can review that complex patient with, the multidisciplinary pain specialist at UW. And they basically will discuss the patient, what's the issues and so forth, and help the kind of on the spot helping the primary care physicians how to manage the patient, and for that. But you're right that for the regular primary care physician, when they don't know about UW program, they may potentially just see that I gotta refer to whatever we have in the network, that pain specialist, which is very difficult to get by, especially if you live in the rural area.
Has anybody in this meeting ever tried to call that UW phone number for assistance with pain management guidance?
Yeah, I have. I don't. I call in now from the VA. I used to be on that ECHO committee or participate in that when I trained at the university, but I've called in now that I don't work at the university. I haven't found it too difficult.
Yeah, and I had actually invited the guy who's running this at UW, but he said Monday afternoon he's doing clinical care and didn't think he'd make it. But I also had participated at one point and can't. So I didn't think it was difficult, but I can ask him about that since he's not on this. I mean,
I had just
I
heard, I
yeah.
had heard historically there were some good and bad things about trying to get into that hotline. Either you're waiting forever and not getting in, or there's nobody there. But that was ages ago, to be honest, and I haven't checked in with anyone lately. So I have no idea if this is like still a super effective resource, which if so, awesome. I don't know.
Billiard, do you
So,
want to just like leave this for further discussion later? I mean, I think, learning about talking to this individual in my department who runs it would be very helpful to answer some of the questions and concerns about access to that network.
sure. I mean, we can definitely defer it to a future workshop. Um, and we have feedback here that supports and does not support the addition of these, the A through E that we're adding to 1, and then we were planning to add a whole new 2. Right now 2 is this, which we've moved to 3. So this is what's in 390 or 930 right now is on the right. And then this is what we're proposing to add.
Ed, you have your hand up.
Yeah, I want to thank everyone for the really cogent conversation about this topic, as controversial as it may seem. Um, I have several concerns here, and one of the things that I have is that for us to never forget that in medicine, it is a collaborative experience, and the better and the more collaborative that providers are, the better providers they are. It is very clear from the statistical standpoint that some of our most problematic providers are working by themselves and don't collaborate. And I think that the reason we have this is for, as already mentioned, guardrails. The commission is committed to public safety, and there are multiple CDC cohort studies to show that MEDs greater than 120 milligrams a day has up to 9 times likelihood of fatal overdoses. So I think there's real clear evidence now to show that we have to practice in the world of opioids with guardrails. And I don't see anywhere where it says you have to, you must, unless you do, you're going to go to jail and not collect $200. No, it says it nowhere. It has an opportunity for men and women who are practicing out there who are saying, I need some guidance. Let me get some guidance. And I think that's what this is about, is safety in the management of opioids. And I think that the better and clearer it is, the more supportive it seems for our providers. And I can tell you that after practicing for 44 years in internal medicine, that I welcome the opportunity for guidelines to be able to make safe decisions for the management of my patients.
Can I ask again why isn't this in the section that applies to all chronic pain patients, not just the ones being referred to specialists? If we feel strongly these guardrails are important for anyone who is getting treatment for chronic pain, then shouldn't it be in 910, which is everyone that's being treated for chronic pain and not just the ones being referred to specialists?
I think one of the differences, Rose, is that people change over the time that they may be receiving prescriptions for chronic opioid therapy. And so the reasons to refer a patient to a expert consultation include some of the descriptors that are described here, a change, meaning lack of meaningful improvement with opioid therapies, or escalation of dose, or accumulation of other comorbidities or medical conditions that could change or potentially change the decision making around this class of drug.
And this is Dr. Chen again. So basically, I see this treatment plan is that this is actually referring to a stable chronic pain, that they don't escalate the dosage. They basically very comfortable staying on one dose. And so this is simply the treatment plan describing what you should be documenting when you see a patient for your regular treatment plan review or the chronic pain visit, to this kind of, so what should you check and so forth. Versus the other one is really talking about, say, well, you have escalating pain, something changed that that's above the comfort level of the primary care physician, then you should consider referral or consultation.
Any other comments about this section?
I guess I'm just befuddled that we're the only state that even has a consult threshold. And now we want to add how many hundreds, thousand more words to it when no other state has it or feels it's necessary. They have guidance and guardrails throughout their prescribing rules, but not under a mandatory consult. So I just find it, why are we different than every other state in that regard? I don't get it.
Well, we'd probably have to go back and look at what happened with this this RCW. So this is in law. So we have to follow the law. So, and we can't make changes to RCWs. So
yeah, I get the sense that like when this law change happened in 2009, 2010, it was kind of a Hail Mary because nobody had any evidence yet at all about prescribing or dosages or anything. So this Hail Mary was go see a pain specialist until we get it sorted. Subsequently, we came in with 1427 and all the prescribing rules, and yet this remains. And I just don't understand why it still needs to be here. I know legally it needs to be here because we legally can't remove it, but it just seems like an odd artifact of a historical era.
So, and something to keep in mind is if you want an RCW changed, you have to contact your representative and talk to them about getting that RCW changed. Go ahead, Maria. You're muted if you're trying to talk.
Sorry.
No, go ahead.
I'm going to go on talking. I wanted to focus again on the part where we talk about deterioration in function and pain. A lot of us with progressive diseases, and I'm one of those, so this kind of hits me. I can be stable and doing great for quite a while, but then something happens and it's just a part of my medical condition where I'm progressing, and so I'm concerned about that part because it a lot of times it's just part of the disease that we have that is going to continue to progress, not necessarily meaning that something is we're doing something wrong or something is bad. So I just want to know that we focus on that part.
Thank you. Go ahead, Cindy.
Yeah, I was wondering, couldn't we look through the suggestions and maybe there's some we want to keep, maybe there's some we don't want to keep, maybe there's a different way to word them. I know that the Higginbottom suggestions had an eloquent way of talking about patients that, hold on one second. My phone went dead. Okay.
Is it
One of the
these
things
here?
she said, it is part, yeah, you have to roll down. So what I have is a patients who have an unexpected dose escalation, not tied to functional or clinical improvement. Second, indicators of overdose history or active substance use disorder. psychiatric instability or diversion concerns, or any other clinical circumstance which additional expertise would reasonably support patient care. And the last sentence is actually up in the section that whoever wrote that suggested. So grabbing a few of them and putting them together might make more sense.
Okay, so you're saying that we should. Okay, we did not use that there. Okay. So I think what we can do is I will go back through the conversation we've had here today and your suggestions, Cindy, and put something new together for 9:30. I will say, let's see.
I mean, Amelia, I didn't mind what was said before about that. Because I think it could be shortened. I don't know if you could have a table of the conditions or some of this stuff if just as examples. I mean, I didn't see the word should consider or consider. I didn't think it said should consider is finding. I mean, it just was to me an educational thing, but maybe trying to shorten it seems like a lot there and, package it differently.
Sure, I can do that. And
Yeah.
then at the next workshop, we can go back over what changes have been made. And so, yeah, I can just review what we've talked about here today and make some changes to this section based on that. And then between now and the next workshop, I think the next workshop is sometime in July. We will take comments, of course, and then if you have specific comments, I'll try to get the revised draft language posted by the end of this week to the website. So you'll have plenty of time to give comments on any changes we proposed to this section. Okay. And we're not making any changes to this one. I think we all agreed to leave the 120, right?
We have to leave something.
Mm-hmm. Okay. So I think we'll leave this part here too until we go. I think that's what we'll focus on at the next workshop is this section. Because it sounds like there's a lot of changes that we want made or, a longer discussion. So that will be the plan right now. And we'll also talk about these additional items at the end. Okay. Now, give me just. Okay, give me just a second here. Hold on. Okay, so the next thing on the agenda is to discuss 890 sub 3. So I'm going to scroll a lot. Well, actually, I'm going to find it, 890. Because we made some changes at the last workshop to sub 3. All right. So it was approved at the last workshop, but we also wanted to discuss them and make sure that some of the revisions we made are still okay with the commissioners and the public. So here is the first thing we changed was this from 3 to 7, which I think everybody was fine with that piece. And then we're proposing removing this sentence about not prescribing beyond 14 days. And we changed it to say when a longer duration is clinically indicated and documented in the patient record, the physician may prescribe more than a 7-day supply of opioids. So commissioners, are you okay with that change?
I am.
Fine
I'm
with
okay.
me.
All right. So this piece was approved. Oh. Oh, okay. I see that message from you, Cindy. I don't have my email open, so that's going to take me a minute. Hold on. And you said for later consideration, which section are you referencing, Cindy?
Oh, I said later because you decided to take language later on the
for
section we just talked
for
about.
9:30.
Yeah.
Got it. Thank
Yeah.
you.
You're welcome.
All right, and then we will talk about this has already been approved. So the next on the agenda is to talk about section 900 sub 2, which we made similar changes there, I think, that we just talked about. Sorry for the scrolling. Okay, sub 2. Same thing. We changed but we took this out completely, this sentence about they shall not prescribe beyond. It was 14 and then we changed to 30. Then we just deleted that sentence altogether. And we changed it to during the subacute phase, when a longer duration is clinically indicated and documented in the patient record, the physician may prescribe more than a 14-day supply of opioids. So are you okay with striking that sentence and changing it to the sentence I just read?
I'm fine with it.
I'm fine.
I am as well.
Agreed.
Okay. And then we will start with 905 sub 3. I'm going to scroll a little bit. This is where we ended the last time, was in sub 3. I don't know if you need a reminder of the changes. So sub 3, 905 is patient evaluation and patient record for chronic pain. So we made a few changes here. And then we got kind of bogged down in sub 3. Okay, so let's go, hold on, let me go back. So let me go back a little bit. So this is where sub 3 starts. So, okay, so what we're talking about is that the physician shall include in the patient's record when they do the evaluation and fill in their record, appropriate history. And then 2 is patient goals and treatment expectations. And then, appropriate physical examination. And then 3 right now says ancillary information and tools to include. And then you started talking about a review of the PMP, and there was a little bit of back and forth, and so we decided to stop there. So that is where we are starting the remainder of the draft languages in sub 3 of 905.
Amelia, what was the back and forth about? We have to look at the PMP.
So, right. And that was a little bit of the back and forth, is that they have, you're required to review the PMP. There's a schedule in 985 of when Now we do have some proposed changes to 985, but there's a schedule of when you're supposed to check it. Also, one of the other things to keep in mind is we are right now proposing removing the definitions for low, moderate, and high risk. And there's some language in 985, which is the PMP section, which talks about the requirements of when to check the PMP. But there's some language in that section about when to check it for a low and when to check it for a moderate and when to check it for high. So I think that was part of why there was a little bit of back and forth, because we're removing those terms from these rules. And so I think that's why we wanted to wait. So you're right, there has to be a review of the PMP. And if we change 985, I think we can still reference it the same way it is here. We don't need to make a change to 3A. But there may be a bigger discussion about what goes into section 985. Which we probably won't get to today.
Yeah, it seems like this, I don't see the problem with 3A. I mean, we have to review a PDMP, and the 985 is kind of the waterfall reference that will instruct us to kind of the frequencies with which that would be required. So it seems like this is all like an accurate and all-encompassing statement.
Mm.
And then this document wouldn't have to be changed if 85 was changed, because it's already incorporated.
Right. And I think that was the big point the last time, is that there has to be a review of the PMP. And that's not something that's really within, the PMP piece is not really within our control. So, yeah, so we have to, it has to be checked by physicians that are prescribing.
Yeah,
funny is-
oh, sorry, go ahead.
I was saying, what's funny is when we were coming up with the rules for 1427, we spent, hundreds of hours defining like how often and quarterly or monthly or, annually, what's the, hammer it all out. And in reality, in my experience, any doctor, any specialty or primary care who's considering prescribing any controlled substance, be it opioid or benzo or stimulant, is 100% checking the PDMP before they get anywhere close to a prescription. So just for their own safety and sanity, right? And also documenting in the medical record that they have done so that they can illustrate that they are compliant with all of the appropriate oversight. So yeah, I don't think we need to mention how often anyone needs to check the PDMP in reality, because people just are. So yeah, I think leave it. I think what's in here is great. It's fine.
And then just to add to that, in the meantime, since we did the rules in 2018, 2019, there's a new rule that the PMP has to be integrated into any system that has an EHR, EMR, has to be integrated. And so I think as part of those systems, it automatically checks the PMP. So, so things have changed. And so that's going to affect what we do in 985 for sure. So, okay. So I think we can move on to 3B. We are suggesting adding or biological specimen test results to 3B. Does anyone have any comments about adding that in?
Was labs not inclusive enough?
So there has been this movement to specifically call out biological specimen test. That's something we defined previously in the last iteration of the rulemaking that we did. And so it just kind of got left out here. And so we had some folks that felt it was important that we added into this section too.
Yeah, I have no objection, obviously, if the clinicians think it's important. It surprises me that we didn't already have this covered, but party on, guys.
Commissioners, are you
Fine with
okay
me.
with adding it? Okay. And
Yeah, fine.
then, so 3D, we changed it a bit because we're trying to move away from risk assessment tool and instead say validated screening or assessment tool when clinically appropriate to this should say evaluate pain instead of evaluation. Pain, function, behavioral health conditions, that's something we would like to add, or risk for adverse outcomes associated with opioid therapy.
Yeah, I agree with this.
I thought Cindy or Cynthia has her hand up.
Did you have a comment, Cindy?
Yep, just got it unmuted. Yeah, we've done a lot of work in looking at the automated decision support tools and the impact they've had on patients in different states. We had suggested before that when you're talking about risk tools, that you say risk assessment tools shall not be risk assessment tools do not include scores generated by automated decision-making systems or automated decision support systems. We're coming up on a scary time with all the AI, and then you talk about the PMP being integrated with the EHR. So I think it's time that we start putting some language in the document about that.
Thoughts from commissioners?
I'm a little unprepared to answer that question. That's really a huge, big ethical question. I think I would need a little bit of time to think about that, to be honest. The proposal or the ask is that we specifically state that any, like, you're using the word automated decision support tools not be scored, automated decision support tools not be included. I mean, I think we use those in other parts of medicine.
We use them all the time for risk predictions and things. So, and they're
Yeah.
also not
Yes.
something that the physician controls. It's often the health system that
The
does.
thing of it is the automated tools currently available are black box algorithms that are proprietary and we don't get to know what's in them. And the analysis of those is that they are no more accurate than a coin toss. So we are loath to hand over control over whether or not a patient gets determined to be at risk or not to an unknown, unvalidated, untested algorithm that we don't get to know what's in it. That's the concern.
I'm just thinking a little bit. I appreciate what you're saying. I understand, the concern that you're raising, and I would say I'm also thinking about other places in anesthesiology where we use things like this, like our spectrometry as an example, where we have automated proprietary calculations of biometrics that give a piece of information. It's not a sole decision maker, but it's a piece of information that a physician can use in combination with other data points in order to guide a general impression. And so I think that there is reference for this type of application in other areas of medicine. And physicians and medical providers are able to take information without being dogmatic about it and take it.
Totally agree. And if this automated risk score was simply one piece of data that a doctor was presented with to make a decision, that'd be fine. But the problem is, say this automated risk score arbitrarily assigns a high risk value to some patient. Now that doctor who may think otherwise, that having met the patient, they're fine. If they've got a high risk score, does that doctor feel pressure to say I had to defend, like, even though this score was high and said this patient was high risk, I prescribed anyway. Like, is there going to be oversight that beats up that doctor for going against a high risk score, even though the high risk score may be completely unfounded? That's the concern. Like, when it's a single piece of data, that's one thing. But our big concern is that people feel pressured to fold to the high risk score number. And that is in fact what has happened across many, many states who've been using these scores. It is, there was a huge article in Wired. There's a number of like legal journal studies about this very problem, arguing against the use of this because it literally denies people healthcare. It denies them pain relief for things that they can't control and they don't get to see or correct, by the way. The algorithm is run against medical records they don't get to see or correct ever. You get to correct your credit score if it's wrong. You don't get to correct your medical record that the algorithm's running on. So that's the concern.
Yeah,
Go ahead,
SO.
Susan. Yeah, go ahead, Susan.
I guess my concern as we talk about this is we have to always remember AI is only as good as what's put into it. So like Rose shared, we don't get to see what's put in. We don't get to see the guidelines. And this is somebody's arbitrary judgment about a person they've never met. And that's very concerning to me because you'll hear all the time, AI is garbage in, garbage out. It's not perfect. And to use that solely to make decisions on how someone's pain is going to be controlled, I don't think is a good idea.
Thank you. So Heather, can we even broach this, the use of AI in this section of rule? Is that something we have the authority to do?
So this section, I'm trying to think. So we're in 900. Is that where we're at?
I think we're in 905. Patient
905.
evaluation.
Okay. Yeah, and so we're talking about what tools they're going to use in the risk assessment, right?
Mm-hmm. Right.
I need to think about that. I think it's going to be problematic. There's a whole movement, right, on the use of AI in medicine and what's what can and can't be used or what is valid and not valid. I think it's a much bigger discussion than just this rule. So let me think about that. But I think it's going to be difficult to say you can't use some sort of risk assessment that might happen to be computer generated here.
Well, and especially when we don't have like a list of the validated ones or ones that we approve, you know what I mean? So, Micah, you probably have an update on this AI.
Actually, I've got an update on both. So yeah, I would need to either myself or Heather go look at the law that passed this year on high risk AI systems and the limitations that Washington State has put on them. But aside from that, the original intent of this section was not AI tools. When we originally were talking about this, we're talking about essentially a instrument that was developed and validated, and so that's what this was originally referring to. I don't remember the names of the ones that we talked about last time, but there were about three that I recall. And if you recall, Dr. Small was quite familiar with them and was referring to those, but we chose not to put the actual names of them. So this is not a section that was envisioned for any sort of black box tool, AI tool, automated tool. It was envisioned for developed instruments for evaluation and assessment. That's it.
I have a question for Dr. Lee. Do people use these things? I mean, as opposed to having a gestalt from meeting the patient and their medical history?
So I once again, I'm going to refer to my experience at the VA. We have a automated support tool at the VA called the stratification tool for risk opioid for opioid risk mitigation, STORM, and it does create a not numerical, but it stratifies risk in categories low to high. And it's a requirement in the VA, and it is used just alongside all other information. And it's not a mandate, you know, it's just a data point that helps physicians you know, gauge how concerned they should be, or whether they should be looking more closely or not at a medication plan. It doesn't have any more or less weight than any other data point, but you know, when we examine when we aim to be comprehensive with our patients, that means that we are open to examining all information available to us. And so I think, you know, it's been effective and helpful in our healthcare system.
Thanks. Was there another comment?
I think Cindy lowered her hand.
Okay.
Oh, she put it back
Oh
up.
no, I didn't. I'm so sorry I didn't. One of the merchandise, I guess we'll call it, from Bamboo is something called Narcs Care. And they did a study on themselves, and they had a 17% risk for high risk. Those patients were primarily disabled, had poor health, or deemed as having increased levels of pain and pain interference. So it's a 17% false high risk score. So that's 70,000 patients in Washington that have high impact chronic pain that would be falsely said to have a risk there. If you have prescribers who are overly leery of prescribing and they're worried, well, I saw this risk score, what should I do if somebody else sees it? So they're going to worry even more that there's something that's saying that that patient is high risk. So it's going to happen more and more. We're going to talk about it more and more. I know it wasn't what was intended in this rule, but it's alive and well. And as patients, we want protection.
So I think what we would, like Heather mentioned, we'll have to do some more research on what we can and can't do in this particular section, what we can and can't do in WAC in regards to restricting or requiring the use of certain things, certain tools. We'll have to look into that deeper, I think. Okay, so outside of the AI discussion, is there any other comments about the changes we're suggesting in 3D? Cindy, did you have your hand raised again? Okay. Okay, looks like we can. Are you okay with these changes that we're suggesting in 3D, commissioners?
I am.
I am.
I'm fine.
Ed gives me thumbs up. Okay. And then we're suggesting adding this 3E, which is review of prior treatment records or care plans when available and clinically relevant.
Yeah, that's
I'd like
appropriate.
I'd like to point out that it would be a dangerous thing not to do that when seeing a patient.
Agreed.
Okay, so we're good with that change. All right. Let me just do both of these. Let me make a note on this one. Okay. All right, and then moving on to sub 4, which is about the assessment. And again, just a reminder that everything that's underlined is things that we're adding or has been suggested that we add. So we're not going to make any changes to A, but we have some suggested language from Maria and her group to B, to change it from what it says now to consideration of the risks and benefits of initiating or continuing opioid treatment in the context of the patient's condition, clinical goals, and prior response to care. So the ask here is, do you want to leave it as is, or do you want to add some elements of the suggested change?
Well, it's more words, but I don't disagree with it.
Yeah, I was going to say it's more words. People were concerned about words, but it seemed fine to me.
I'm okay with it. With the change.
Okay, so we're good with that. And then we're suggesting changing, let's see. This is also, let's see. We are suggesting what's in the underlined, and then we've got an additional suggestion from from Maria. These are very different.
I'm not sure what is meant by impact on pain. So usually the ways that we evaluate, one of the ways that we evaluate continuity of any medication, whether it's an anti-inflammatory or an opioid, is whether it's providing pain relief and also enabling function. So I don't really know what impact on pain means. And quality of life is that's a very subjective thing. That would be hard to measure or how, that's just subjective.
We could swap in, ability to perform ADLs.
And
yeah, but many people, are not, that's very limiting. Many people that are disabled, physically disabled, may not be able to perform ADLs, but other functions could be relevant to considering the therapy.
Right. I'm saying if we had it as one of the things on this list, it'd be an inclusive list. So like,
yeah, I'm open to shifts. I just think that ultimately, like pain report, unfortunately, no, we can't see or measure pain, so we do have to use something like a numerical rating scale or such, a number. Unfortunately, that's where we're at. And also function are the things that I think we're trying to glean from C. we could reword it, but some of this I don't know how what that adds. Progress toward treatment goals is a good thing, though. I like that. Because that, that describes, collaboration with the patient.
So do we think we can leave the patient's response to treatment and progress towards treatment goals?
How do we feel about doing pain, function, and progress toward treatment goals?
Towards pain function. Okay, patient's pain function.
I think that works because I would argue that your quality of life is impacted by whether or not your pain is and functionality is being impacted. So pain, function, and progress for treatment goals. Maria, what do you think? Does that get it done?
Yes, I agree.
Okay, so we're good with this now, yes? Oh, Cindy, you had a comment?
Yeah, you guys might want to look. There is a questionnaire that you receive at the pain practice every month, and it has to do with pain, function, and quality of life is in the questionnaire. So we might want to look at that and see if that's something that's being used already. We might not want to change it.
Yeah, you're referring to the PEG score, PEG. Yeah, and it's pain, 0 through 10, enjoyment of life, 0 through 10, and function, 0 through 10. And that, when we talked about above, we talked about evidence-based or validated pain assessments. That would be among those that would be included in that section.
I was going to say, I've been seeing pain specialists for 20 years, and there has been some flavor of that type of assessment, either required by Medicare or by the clinic. They've not always been the same. They've been different, but there's always like, how is your pain level? How's your functionality level? Or do you have anxiety? Do you have depression? Blah, 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 all of that. So yeah, I'd be surprised if not every pain specialist was requiring that.
This is Heather. I think you need a comma. Are you talking about pain, function, and progress are 3 things? Maybe a comma between pain and function.
Well, we're going to use this Oxford comma too.
Okay.
Okay. How are we with that change then? We okay with that? Did you have a question or something, Cindy?
Yes, I'm sorry. It's really hard
Okay.
to see where I'm at. I apologize. I'm not comfortable with the progress word. I really think it should be quality of life. Progress is showing that you have to achieve something more when you have a disability. I don't like that.
Well, treatment goals are, we can talk about changing that, but treatment goals those are something that the physician doesn't assign. That's something that goals are something that a patient and a physician discuss together. So it could be improved sleep, it could be ability to communicate or participate in family functions. Goals, I think treatment goals doesn't have to sound like a physical therapy measurement or something, or like gonna walk more or something. It's what are the goals of treatment, and it may be, these are going to be defined by the patient and the physician together.
And if I'm not mistaken, this section literally just says the physician shall include in the patient's record, not make decisions based on, just document in the patient record. Is that right?
It says assessment. The physician must document medical decision making to include sub A, B, C, D.
Got it. I got lost in the letters. Sorry.
Yeah. I have the current one pulled up That's the only reason I would say that. It's very confusing when we have all these underlined and struck through and all of that. So
Okay, so should we put a pin in this one then?
well, I mean, I mean, the commissioners can make a decision whether they want to keep that progress toward treatment goals.
I'm
Since
okay
we're
with the language as
physicians, I'm
is.
fine with keeping progress towards treatment goals.
And you still like the patient's pain function and progress towards treatment goals. Okay.
Cindy, would you feel better if quality of life was also in there?
Absolutely.
Does
But
anybody
what
object to?
I think Dr. Lee did, she said that didn't you say that it wasn't really, quality of life wasn't really something that it's like measurable or?
I mean, what I guess I just think it was included in other sections, but I mean, there we just this is a lot of I think it's a lot of words that kind of say the same thing. So if we want to use progress toward goals or quality of life, function, pain, I mean, I think these are all the things that are described multiple ways already in this document.
Yeah, but specifically here, it's medical decision making.
Yeah, as well as above in the when we talked about validated tools, those things are included in those as well.
So would you be okay with adding it like pain, function, quality of life, and progress towards treatment goals?
Yeah, that I mean it's not harmful. It's just as we said, I thought we were trying to be pared down on words. That was a concern described earlier. So
These three
I think
words I'll
there's
take since we added 1,000 more in that section.
I mean, we
It's
did
fine with me to
eliminate.
add the extra words.
Yeah, we did
yeah.
Pare
eliminate
down
some.
later.
Okay, Ed, did you have a comment? Sorry. No, okay. All right, so we're good with this now. Patient's pain, function, quality of life, and progress toward treatment goals. Good. Yes. Okay. And we'll highlight this one. Okay, so then we have suggested what's in the underlined instead of it just saying pertinent concerns discovered in the PMP. We want to change it to say pertinent concerns identified through review, consultations, or other clinical information. Oh, PMP review, consultations, and other clinical information. And then the suggested change from Maria's red line is just to say pertinent concerns or notable finding from the PMP review. So this is our suggestion, and then this is the one from the red line. Do you have a preference?
Isn't your suggestion more comprehensive? That's why I like that.
Mm-hmm. Looks good.
Okay. Go ahead, Cindy.
I don't know why my hand raising is going up because I didn't raise it.
Oh, okay. Well, maybe it was just still left up. Who knows?
Thank you, though. I appreciate it.
All right. Oh, gotta send. All right. And then our suggested change to 5, right now it just says treatment plan is provided in WAC 910. And we want to change it to documentation of clinical decision-making, including the rationale for any exemption or exception applicable under this chapter. And I think the reason we added that about the exemption or exception is because we may possibly make some changes to the exclusions section. If we end
Amelia,
up
this
not
chapter means the whole thing, right?
right,
This
the
document.
whole, not just this document, but the whole chapter. So it'd
Okay.
be the whole chapter 246-919 whack, the whole chapter.
I'm wondering if we need to state if people don't understand what chapter it is.
What's your thoughts on that, Heather, if you're still here?
You see the type one
There she
before
is.
says what it is.
Right, because it's specific to that section. But
So let me see. So you're wanting, tell me again
I
what
just
you're,
didn't know the chapter. Is it this document? Is it the whole whack
okay.
thing? What is a chapter? Is a
Chapter is going to be
a section of the
generally it's the
document?
no, it's the larger WAC. So WAC 246919 would be the chapter. So so if you want to limit it, you can put the exact
to the
WAC
exclusion
reference
section
there, or yeah.
I don't care. I just was thinking people may not know what this chapter is.
If we want to just point out the exclusion section, that's section 851.
That might be good.
Exclusion. That's what it's called. Okay. Are we good with that now? It says yes.
Yes.
If you said anything, Dr. Domino, I couldn't hear you.
Yes.
Okay.
Yep, that's fine.
All right, so we're done with most of that section. So we can move on to 910. All right. So Micah, do you want to speak to this question if you're still here? Oh, I don't see him now.
Of course I'm here.
Oh, there you are. You disappeared off my
leave.
screen.
Yeah.
So, you have this question if we need to even mention this about treatment plan, right? You're talking about the whole section, right?
Yeah, I'm just talking about 910, the concept of the treatment plan. In addition to the language that speaks to subacute transitioning to chronic, it does talk about having to do a complete reevaluation as if a new disease is presenting. And so my question really to the clinicians is, wouldn't this just already be part of your standard practice and standard of care to have a treatment plan when a chronic pain patient crosses your desk? And so in the interest of that, if that is true, do we need to have this as a section if it's just a standardized operating procedure that you already have?
So, Mike, I'll take that. I think for most or usual, the answer is yes. But most or usual does not take everybody in. As you know, probably better than I do, that there are different practices all over the state. Some physicians don't even have an EMR, as odd as that may seem, practicing on a scratch paper. And so I think it's important that, in my mind, that we have delineated in 910 what the expectation is. My thought only.
Do we have treatment plans in the acute and subacute? I mean, the requirement to document a treatment plan in those sections or just chronic?
Let me look. Subacute treatment plan. Acute treatment plan. Yes, both of them have. In fact, acute has one for non-operative and one for perioperative. So they both have those sections.
I mean, they have those sections, but they have this bullet that says you gotta have a. So I'm just saying, if we could kill all of them, great. It feels weird to kill just one, but I agree with Mike. It seems a little rudimentary to say like, yep, hey doctor, maybe you should have a treatment plan.
So this is for acute non-operative pain. This is what it like change in pain level. So it does have a list. So it is a little similar. So that's a bigger conversation if we decide to take all 4 treatment plan sections out of rule.
Amelia, do we have sort of like a global section that applies to everything throughout the rule?
For like a no, not really. I mean, we have the intent and scope, but again, it doesn't have any requirements in it. So I would say no. I mean, each like acute has the evaluation and then a treatment plan. Subacute has evaluation and then treatment plan and then chronic. So they all sort of follow. I mean, chronic obviously has all these other sections in them. So yeah, they all sort of follow the same pattern, I would say. And then, I just added this comment about since we're moving towards this more individualized medical decision-making model, keeping this section, it just gives physicians out there who are prescribing to a chronic pain patient, it just gives them like a framework. I don't know if that's important that they have a framework, if that is just part of what they do. So, and then,
I think this is
we're
really important. Yeah,
okay.
I think this is really important. And sometimes, I mean, establishing sort of like guardrails, which was previously mentioned, is one part of opioid pain prescribing, but also having a a backbone for what you're trying to achieve. No, so often patients are prescribed pain for unclear reason, or prescribed medicines for unclear reasons, and we owe it to our patients to have a pain-related diagnosis and a plan for their care, and not have it just be a wash and repeat, refill the prescription every 38 days or 28 days or 30 days. I think that, this is incredibly important that we codify that we have to have a plan for this type of care.
Do we have any rules anywhere else in in WMC, in the prescribing rules that govern doctors? Do we have anywhere else in medicine where we have to tell a doctor that they need to have a treatment plan documented? Or
Well,
just here?
Rose, we don't actually have any other prescribing rules. These are the only ones we have because we were directed to do that by statute.
Yeah.
So nowhere else has anyone felt the need to put in the rules anywhere that a doctor has to have a treatment plan before they write a prescription
There's no
or whatever it may
statute.
be.
We're
That's what I'm
following
saying.
statute.
But
Yeah.
no one has ever felt the need to add a statute that says we need to tell doctors how to practice medicine to the point that we need to tell them to write a treatment plan to prescribe chemo or an NSAID or blood pressure medication. No, doctors know how to do that because treatment plans, but
I don't see it as being offensive. I think it just is educational.
And I think it's underlining the quality of care that we require doctors to provide to chronic pain patients who are deserving of that level of consideration and assessment. It's about committing to understanding the cause of your patient's pain and having an evidence-based plan for how to optimally treat it. It's supportive.
And I'd like to reiterate, if I may, the importance of safety prescribing, not just prescribing, safe prescribing. And I think this is very helpful to reiterate to the provider, whoever that may be, the importance of safe prescribing.
Sure. And like I said, when I took my first run through the existing rules, part of what I was trying to balance with respect to the feedback that we've gotten over the years is how much is in the rules and how to reduce it, but also responding back to the patient community about what they felt might be barriers or anything that seems to be running up into difficulties in getting care. Not necessarily saying that a treatment plan is that, but it certainly was a question that I wanted to raise of, do we need this? And so I think I find that it's helpful to even just ask as we go through things that aren't, blatantly obvious, like the PNP section. We can't eliminate that, so we do have to say we need it, but that's the basis for the question. Thank you.
So these are the only, what's underlined here and then what's struck out are the only suggested changes to this section. So if we can go through those and either change them or approve them, this will be the last section that we talk about today. So do you have any comments about the suggested changes? And these are based on feedback from previous workshops and comments that we've received.
I just have a question. So if these come under each of the certain phases, acute, whatever, subacute, whatever you call, is there a lot of redundancy in that, so that you don't have to say the same thing over and over again? I'm assuming from acute to chronic, it's different, but I just curious. Micah, when you went through, what did you think, or Amelia, what do you think?
So they are different. And because of the way our rules are structured, and they're not just our rules, like every board and commission has similar rules. They're all broken out by the phase of pain. So they're all broken out by acute, subacute, and chronic. All of the other boards and commissions have the same breakout. So there is some redundancy, but like I'm looking at subacute pain right now, and it's pretty different. So from what we have
Yeah,
here.
that's fine. Then we need all of them. I was just
Yeah.
trying to see if there's some redundancy in this.
It would be nice if we could condense them, that's for sure.
I am wondering, when we get to the exemptions and exclusions section in a future meeting, if we're talking about, I think what we were proposing is some level of exemption for stable patients, stable chronic pain patients, then does some of this become unnecessary or redundant? Because if you have an unstable chronic pain patient, are you actually still prescribing at that point? Because that would seem wild. But so it just occurs to me that we might need to circle back to this depending on what we decide on. Yeah, okay.
Yeah, we definitely will. So once we talk about the exclusion section and the commissioners agree to whatever changes we're making there will have to be a top-down re-review of the other sections to see where we need to make some changes based on, whatever is included in the exclusion section. For sure. That's a good point. Okay, Commissioner, so how do you feel about these proposed changes to this? And it's only this part. We've not proposed any changes to the latter part of this section.
I'm okay with it.
It's fine, and it's now 2:50.
Yeah.
Agree.
Are you good, Ed? Thumbs up. All right. All right, Dr. Domino, you can read the at 250 part of the script.
Yeah. We will now continue our discussion of the draft language at the next workshop. Thanks everyone for your participation. Ms. Boyd, please discuss our next steps.
Okay, let me get all situated here. First, I have to stop sharing. Then I have to reshare my presentation. And I apologize, it will start at the beginning. And it will take it a hot minute, apparently. All right. Let me get to where I need to be. Oh, I just wanted to mention that because we've had some questions about this, then we were just talking about it. So these 3 sections, we will discuss them once all the other sections of the language have been reviewed and approved. And the reason is that we want to ensure consistency across the rule set. So we will postpone it until either a later workshop or the last workshop, because proposed changes elsewhere in the rules may require additional revisions to each of these sections language. Any questions about that? Okay. So the next steps for this rulemaking are additional workshops. I'm hoping that by the end of this week, I will have the revised draft language posted to this rules page. And then you can navigate to that page by clicking on the slide, the little globe icon on the slide. Once that draft language is posted, we will send out a notice via our Gov delivery list. And then when the materials for this workshop, for the next workshop are available, they'll be posted to, or they'll be sent out, the notice will be sent out through Gov delivery. And also on this rules page, if you go to this rules page, we post the materials from previous workshops as well as the link to the recording for previous workshops. So all of the information about this rulemaking will be on that page, except for the registration links for future workshops. Those are all out on the main rules in progress page. So, which is just a page back from this rules page. That is all I have, Dr. Domino. You can continue the script.
Okay, well, are there any questions that have not been addressed?
I have one quick question. Amelia, do you know what will be the sections we're discussing in the next meeting already, or do you decide later?
So I will know by the end of this week. Whenever I get the draft revised, I'll know, I'll have more information about what we'll probably talk about. At some point, we have to talk about those these proposed new sections. At some point, we have to talk about those. And I will probably consult with Maria about those, whether they're still necessary after all the changes are made. So, but yeah, I should know once I get that draft language revised and posted to the website, because I know where we'll start and we'll go back and discuss one of the sections we talked about today and things like that. So yeah, I should know.
Awesome. Thanks, Amelia. We will not bug you before Friday.
Well, I can send
Any
that
other
out to you when
questions?
I revise it. Sorry about that, Dr. Domino.
Yeah. Any other questions? Seeing none, I'll now close the workshop. It's 2:54 p.m. Thanks everyone for your participation.
Thanks,
Thanks,
everyone.
everyone.